Welcome to This Explainer. Today, we're embarking on what is honestly a high-stakes investigation. You see, diagnosing neurologic diseases is actually a lot like a classic detective story. You've got a patient presenting with clues, symptoms and signs, and it's your job to piece them together to uncover the culprit. But you can't just guess, right? You absolutely need a systematic, structured approach to make sure you don't miss anything critical. Because in neurology, time and accuracy are very often the difference between a full recovery and permanent disability. So here's our agenda for today. We'll start with the global burden, move on to asking, where is the lesion, followed by what is the lesion? Then we'll cover the neurologic screening exam, and finally, those high-yield urgent red flags. All right, let's jump into Section 1, the global neurologic burden. Before we get into exactly how to investigate these diseases, we really need to understand why mastering this structured approach is so absolutely vital today. According to the World Health Organization, nearly 1 in 3 individuals is affected by a neurologic disorder. 1 in 3. That's staggering. These conditions represent the leading cause of disability and the second leading cause of death worldwide. Just look at these proportional contributions to the overall burden. Those massive sections you see dedicated to strokes, Alzheimer's disease, and other dementias, those represent numbers that have shot up significantly over the past 30 years. And thanks to aging populations and metabolic risks, they're actually expected to double by 2050. The good news is, therapies now exist for many of these disorders, but that means a skillful, highly logical approach to diagnosis is essential. We can't just rely on incredibly costly neuroimaging right out of the gate, We really need the right framework first. Which brings us to Section 2. Where is the lesion? Whenever you're faced with a neurologic complaint, your absolute first priority, literally before you even start thinking about specific diseases, is to ask, where is the lesion? We have to identify the specific region of the nervous system that's actually responsible for the symptoms. Answering this question basically maps out our physical clues. We look at the history, we direct our examination, and we figure out, okay, is this problem in the central nervous system or the peripheral nervous system? Is it mapped to one specific location, or is it kind of diffuse all over? Doing this accomplishes something incredibly important. It limits our possible suspect list to a manageable, finite number. And more importantly, it safeguards us against serious diagnostic errors. For example, say a patient has recurrent vertigo, diplopia, and nystagmus. Your brain shouldn't immediately jump to a specific etiology like multiple sclerosis. It should jump to the location, brainstem. If you do that, you're not going to miss something like a treatable brainstem malformation. And real clinical imaging anchors this abstract concept of localization perfectly. Notice that bright focal region of reduced diffusion pointed out by the arrow? That visually pinpoints the exact location of the issue. In this specific case, it's evidence of cerebral ischemia in the left parietal lobe. So, once we use our history and exam to answer where is the lesion, we can then use targeted technology to confirm it. Let's move on to Section 3. What is the lesion? Okay, so the location is locked down. Now we move to the second pillar of our investigation. This second foundational question, what is the lesion, shifts our entire focus away from the anatomy and toward the underlying pathophysiology. Basically, what is the actual disease process causing this damage? Well, the temporal course of the illness is perhaps your single greatest clue. A sudden onset, where symptoms just appear out of nowhere in seconds or minutes, that usually indicates a vascular event, like a stroke or maybe a seizure or migraine. Now, if the symptoms have a gradual evolution over hours or days, you're likely looking at a toxic, metabolic, infectious, or inflammatory process. And if it's a slow, progressive decline without any remission over months or years, that is classic for neurodegenerative disorders, things like Alzheimer's or Parkinson's disease. Furthermore, the specific nature of the symptoms gives away the lesion's true identity too. Primary neuronal disorders, the ones affecting the gray matter, often present early on as cognitive disturbances, movement disorders, or seizures. On the flip side, disorders of the connecting pathways, the white matter, produce what we call long-tract manifestations, meaning you'll see issues traveling down specific motor, sensory, or visual pathways. This is such a brilliant distinction because it helps you continuously narrow down your suspect list based purely on how the patient presents. Which leads perfectly into Section 4, the neurologic screening exam. So we have our location, we have our suspected mechanism. Now it's time for the interrogation. We need a clinical examination to confirm our deductions. I know, the neurologic exam can seem daunting, but it actually flows in a highly logical sequence. It moves from mental status, right to the cranial nerves, down through motor function, then sensory function, and finally to gait and coordination. It's essentially testing how these multiple systems function in a highly integrated way. Now, while mastery of the full comprehensive neurologic examination is obviously vital for neurologists, knowing a focused screening exam is essential for all clinicians, especially generalists. A comprehensive exam takes significant time. It explores every minute detail. But a really effective screening examination, that can actually be completed in just 3 to 5 minutes. This provides just incredible efficiency for primary care providers who need to rapidly assess for major dysfunction in a patient who, say, has no obvious neurologic symptoms yet. Think about it. In just a few minutes, you can check communication and recall for mental status. You can check pupillary size, reactivity, and facial movements to screen those cranial nerves. You can test for pronator drift to assess motor tone and check for upper motor neuron lesions. You can check light touch in the distal extremities and do a quick Romberg test for sensory function. And finally, you just observe the patient walking normally and then along a straight line. If these high-yield tests are normal, major neurologic dysfunction is pretty unlikely. But if there's an abnormality, boom, you know exactly where to investigate further. Finally, we reach Section 5, High-Yield Urgent Red Flags. This is all about recognizing when a situation is critical and knowing exactly when to escalate things immediately. Honestly, the most important task for a primary care clinician faced with a new neurologic complaint is just assessing the urgency. You absolutely must rapidly identify patients who are likely to have nervous system infections, acute strokes, or spinal cord compression. Why? Because these are highly treatable, but incredibly time-sensitive conditions. Missing these red flags can lead to devastating permanent damage. That's why immediate arrangement for specialist care and advanced imaging is the top priority here. Take an acute stroke, for example. Look at this MRI showing acute ischemic infarcts. Notice how the diffusion-weighted images reveal these bright regions in the tissue? That's consistent with acute brain ischemia occurring within just minutes to hours of the stroke onset. Rapidly visualizing this is so critical. MRI is vastly superior to a standard CT scan for identifying these early ischemic infarctions, particularly in the posterior parts of the brain. And catching this early dictates time-sensitive, literally life-saving treatments like intravenous thrombolysis or stent retrieval thrombectomy. Always remember, time is brain. But because patients often have no idea they're having a stroke, or they simply can't communicate it, bystanders and clinicians alike need a rapid assessment tool. This brings us to a simple, life-saving acronym: FAST: facial weakness, arm weakness, speech abnormality, and time. It's incredibly simple, right? But teaching this to the lay public and keeping it top of mind in the clinic ensures that the most common physical symptoms of stroke trigger immediate emergency action. And to really understand why checking for arm or facial weakness is so prominent in that FAST acronym, consider this staggering statistic. Nearly 85% of ischemic stroke patients have hemiparesis, which means weakness on one side of the body. 85%. This proves exactly why a quick check for one-sided weakness, like looking for a pronator drift during our 3-minute screening exam, is such a critical, high-yield part of your assessment. So let's wrap this up. We've covered the heavy global burden, the foundational method of localizing and defining the lesion, the sheer efficiency of the screening exam, and the life-saving importance of catching those urgent red flags. By avoiding the trap of simply guessing the disease and instead methodically following the evidence, you can solve the case accurately and efficiently every time. So the next time you face a complex medical mystery, will you remember to step back, put on your detective hat, and ask, where is the lesion and what is the lesion? Keep exploring, and thanks for joining me on this explainer.